Hi, it's Peter O'Kane. I'm a consultant interventional cardiologist here at the Royal Bournemouth Hospital, Dorset in the UK.
Hi, I'm Jahangir Din. I'm a consultant interventional cardiologist at the Royal Bournemouth Hospital.
There's a 79-year-old lady who presented last week with an acute coronary syndrome. She's had a previous stent to the right coronary artery, which are both bare metal, dilated up to 4.0 millimeters back in 2008. On Friday, I treated the circumflex, what was a severe stenosis with OCT guidance, got a very good result. And today reported back to treat the secluded vessel based on the fact that the echo shows the ventricle is fully viable and contracting well.
So we've gone biradial just to get guidance off the retrograde filling past the occlusion, and we've actually managed to wire, Peter's managed to wire quite easily across this occlusion with the workhorse wire and microcatheter support.
Having wired the vessel, we then pre-dilated the lesion with a 2.0 balloon. That restored TIMI3 flows. We could de-escalate the case by removing the retrograde kit. We were then able to do some intracoronary imaging to understand the mechanism of stent failure.
The intracoronary imaging we've used is with OCT. That's been particularly helpful in identifying that this is neoatherosclerosis with possibly some plaque rupture and thrombus. The old stent looks well expanded and is buried under the neointima. So with that information, we can then move on to try and treat. We're setting up to use some laser atherectomy now. And you're going to tell me about which laser catheter you've chosen and what we're hoping the laser will achieve for us.
Okay, so in this situation, we're using laser really to try and debulk some of the material within the stent, which will hopefully, when we put a new stent in, we'll have less recoil and less material for the stent to go up against. In terms of catheter selection here, because we're 7 French, we can go up to 1.7 millimeters, which I think is a good choice because we don't really need high energy output in this situation because it's soft material. But we want to try and maximize the luminal gain or the luminal material we can debulk. And if we're 1.7, we'll probably create a lumen of around 1.7 to 2.0 with our laser catheter. Yeah, so there's kind of two components to this catheter, I guess. There's a back end and a front end. So the back end is that's obviously the bit that doesn't go into the patient, which is plugged into the machine. That's called a proximal coupler. And then at the front end, we have a really nice tapered tip here, very fine. Hold it still. It's a very short monorail, just 3 centimeters, and it's a very highly deliverable tip. So first run, I'm just barely going to move it.
Great. So we delivered about 7,000 pulses with the 1.7 laser catheter, and that's been fairly straightforward. So we've got a really good result post laser atherectomy with TIMI3 flow preserved, and we're now using the imaging guidance to choose an appropriate size of stent and length of stent, and it looks like we can treat this with one new drug-eluting stent. And the OCT has shown that we've ablated quite a bit of the tissue within the stent, and we're now happy to use, again, the OCT guidance to deploy a drug-eluting stent.
So we're able to accurately measure the length and the diameter of the stent. We've chosen a 3.5 38mm Zion stent, which we have deployed and then subsequently post-dilated with a 4.0 and a 3.75 non-compliant balloon, which has given us a very good angiographic result. And we're just waiting now for the OCT.
Excellent OCT result together with the angiographic result. So we're happy that we've treated this lesion and the patient should have a good and durable outcome.